Here at CHEST 2015 in Montreal, Thomas Baldrick, joined now by Dr. Victor Test, who chaired a session, Controversies in Pulmonary Embolism, Deep Venous Thrombosis. Thank you, sir, for coming by.
Thank you, Thomas.
What was this session primarily focused on?
Well, this session was focused on a subset, really two subsets of patients with pulmonary embolism. The first is the patient with the so-called submassive pulmonary embolism. And what that is not just a large clot that you can see on X-ray or CAT scan, but a clot that is actually limiting the heart function. Not so much to put the patient into shock, which is manifested by low blood pressure and extreme decrease in oxygen levels, but more the patient who's at risk for bad outcome because of a large burden of clot. And so we looked at a variety of different parts of the discussion, including should we put in IVC filters. IVC filters have been shown to prevent short-term pulmonary embolism, but not long-term pulmonary embolism. And so because of that, their use has become a little less common than it once was. And Dr. Morris in his presentation felt, and I actually concur, that there are patients who fall out of the normal indication, which is thrombosis with the inability to be placed on blood thinner because of bleeding risks, but these other patients may benefit from IVC filters in short term to prevent them from having catastrophic pulmonary embolism. The second lecture was by Dr. Richard Chanik, and it addressed a form of therapy to dissolve clots more actively. Most of our blood thinners actually prevent new clot from forming, and your body has to dissolve the clot itself. And he discussed therapies using catheters to dissolve the clot and how that can be useful. And then the third lecture was by Dr. Susan Murin, looking at the use of IV medications that actively dissolve clots, so-called throbolytics, and what their indication is. And what we know from the studies is that those therapies don't actually decrease the mortality in patients with submassive PE, but they can prevent patients who begin from declining. And in general, they still should be used with caution because they have significant bleeding risk. But in the patient with submassive pulmonary embolism who begins to decline, they can improve outcomes.
What criteria do you use for determining which patients are eligible for?
Well, the diagnosis, the treatment of submassive pulmonary embolism is still controversial, and there's a lot of disagreement. In some centers, they're much more aggressive with clot-busting medications or catheter-based therapies. Other centers are still very, very conservative because we haven't been able to show that an aggressive intervention necessarily improves mortality or long-term outcomes. But in general, what we look at to help us decide is the clot submassive or is it just a blood clot that we can treat with standard anticoagulation, is how does the heart deal with that? Is the right ventricle enlarged? Is it squeezing the way it's supposed to? Is there evidence by blood test of heart strain as manifested by the blood test called the pro-BNP or the troponin I? There are other measures we can use like imaging on CAT scan to look at relative sizes of the right ventricle and the left ventricle. And those combination of things are really what we use to decide is the patient submassive or not. It then becomes a clinical judgment and on the behalf of the practitioner on whether to use systemic thrombolytic therapy or should use catheter-based thrombolytic therapy or should you just use anticoagulation. And that particular decision is still very poorly guided by the literature. But what we do know is that those patients who have these changes are at risk for decline. And once they begin to decline, then they probably need a more aggressive therapy than just standard anticoagulation.
Thank you, doctor. We'll leave it there. Appreciate your time.
Thank you.